So I think we had a very masterful lecture on all the various guidelines and how to manage type 2 diabetes. So the take-home message is type 2 diabetes is very complicated. If you look at the ADA goals of therapy, you realize that there are 8 goals you have to look at. And when you see a patient with diabetes in front of you, you looked at the ACE guidelines. They have now included liver protection as one of the things that you should be doing. And when you look at all these guidelines, you look at the wheel, you have to look at so many things before you decide on drugs. So I'm going to talk a slightly different thing. I'm going to talk about whether we can, do all this with a single combination of two drugs, an SGLT2 inhibitor, DPP4. Fortunately, Dr. Chawla, because now we have generic combinations of DPP4 and SGLT, the financial issues is also taken care of. And when you have a patient in our OPD, we cannot look at all these 8 goals because it becomes very difficult. So what I do is I've taken this from what we learn in community medicine, the Maslow's hierarchy of needs. So when you have a patient in front of you, you cannot have all these goals together, but you have a hierarchy. You do one thing at a time, and in about 3 to 4 visits, you may be able to get things under control. So this is what my pyramid looks like, the hierarchy of needs in metabolic control. Obviously, the first thing to start with is symptom control, and what the patient's felt need was. If the patient came with an infection, you need to treat the infection. If the patient came with hyperosmolar symptoms, you need to treat that. The second thing, the patient comes to you as a diabetologist or an endocrinologist, he's to some extent focused on glucose control. If he's not seeing those changes in numbers, he's going to get unhappy with you. The second part of my pyramid is what I call glucose control. The third part is what is called the icing on the cake. And this is what I think most of us are focusing on, but we have to focus on the pyramid, base of the pyramid before we go on to what we call the icing on the cake. The icing on the cake is something that we have done now for almost 10, 20 years since UKPDS came. We realized that we could reduce microvascular complications by achieving a certain target. 7 is what ADA believes, 6.5 is what ACE believes. But these are all based on vasculometabolic health, microvascular outcomes. Some macrovascular outcomes, but primarily if it was early stage diabetes, less than 10 years, you could do good in terms of macrovascular outcomes as well. Now I think you've seen the ACE guidelines, it's an obesity-based guideline as well. So we have what we call chronic control, obesity-based outcome, what we call barometabolic outcomes. We want to improve weight. Previously our main goal was avoid weight gain. Now our goal is not just avoid weight gain, we want to see 5% weight reduction. If you want to see diabetes remission, you need at least 15% weight reduction. So that is another part of the hierarchy. After vasculometabolic health, you need to ask yourself, can you get better barometabolic health? And on top of the pyramid is what I call viscerometabolic health. That includes improvement in liver steatosis, improvement in obstructive sleep apnea, gonadal health. We have women who want to get better reproductive health. We have men who want to get better testosterone levels, which can be achieved with weight reduction, with glucose control. I think that is the tip of what I call the icing of the cake. And if we can do all this as a pyramid and with a single drug, it's a great idea. And it becomes very easy for me because I do not have to then refer to the wheel and decide which are the things that I want to do. So this is what I'm going to talk about. And in vasculometabolic health, I'm talking about 3 things. We always talked about microvascular health. We talked about macrovascular health. And now, of late, we are also talking about heart failure protection. And all these 3 together, you could call as cardiorenal metabolic syndrome or CaReMe syndrome. And we realize that some of these are very interrelated. That means the heart and the kidney are very interrelated with hyperglycemia, with insulin resistance, with oxidative and neurohormonal reflexes, with fluid overload. So there is significant interrelationship between all these complications. And you realize that almost all these complications have a 2 to 4-fold increased risk in diabetes, whether it is cardiovascular disease, whether it is stroke risk, or whether it is heart failure risk. It's almost 2 to 5-fold more in patients with type 2 diabetes. But here we suddenly start thinking every one of these complications should be given the same kind of attention. Probably not. The reason why I think heart failure is king among all this is if you look at the first presentation of cardiac problems in patients, this is a large cohort of about 1.9 million. So commonest presentation was not an MI or a CVA, it was actually hospitalization for heart failure, for cardiovascular disease. So I think the FDA for many years has concentrated on MACE outcomes, on heart failure, on CVA, non-fatal MI, and cardiac death. But we now realize that heart failure is much more commoner as a presentation, and this is one reason why heart failure is king. The second reason why heart failure is king is if you look at mortality data. We have done very well with MI. We have statins, we have stents, we have antiplatelet agents, lots of antiplatelet agents. You can see the blue lines in this are the blue lines here are what the MI death rates are. Look at what the heart failure death rate is, right on the top there, along with peripheral vascular disease. Again, this is one area where we have not done very well. This is about 1.5 lakh patients. So this is the reason when I think about that base, the vasculometabolic health, I think heart failure is king, much more than strokes and myocardial infarctions. And this is heart failure development. At any year, you can see the highest 5-year absolute and relative risk of death. Now, renal disease is also there. Just below heart failure, just below peripheral artery disease is renal failure. And you know that renal disease in people with diabetes is very common. 40% of them will develop, and diabetes is the leading cause. And now we know the interactions between kidney and when you have heart failure, the body tries to protect the heart by measures which is going to damage the kidney. When you have kidney failure, the body tries to protect the body from kidney failure and it is the byproduct of that, it might damage the heart. So it is a bad loop. And that is why I think Dr. Chawla already showed us these guidelines. All these guidelines are now completely focused on vasculometabolic health, that is heart failure, renal failure, and cardiovascular disease. You can see the primary part of all the treatment guidelines in diabetes, whether it is ADA, it is focused on heart failure, heart disease, and renal disease. Whether it is ACE, it's also focused the same way. You have glucose control, which is metabolic control, but additionally you have heart failure and renal disease, which are concentrated here in the middle part of the guideline. Whether it is the ESC EASD guideline, again, primarily focusing on heart failure, renal disease, and atherosclerotic cardiovascular disease. So now the question is, it's a big pyramid, and we have so many things on the pyramid. Can we achieve all this with a simple combination of an SGLT2 DPP4 inhibitor? Whether this is the key. If we consider that glucose control is the key, I think this is a drug with extremely good glucose control. I think one of the reasons is that it is going to work on multiple pathophysiologies which underlie any patient with type 2 diabetes. It also has complementary effect. You know that when you lose glucose in your urine, you are going to have a hyperglucogonemia. That is the response of the body when you lose calories. And you know that DPP4 inhibitors have direct action on alpha cells to reduce that hyperglucogonemia. So it has complementary actions. It also has significant efficacy versus using those drugs individually. This is a large meta-analysis looking at the combination of SGLT2. Now, you remember, these are various combinations. There are patented combinations available. There are generic combinations currently available. And this is a study of all the trials. And you can see HbA1c difference between using a combination of SGLT2 DPP4 versus just DPP4 alone is about 0.62%, remembering that these are all patients with a baseline HbA1c of about 8%. So it is significant here, 0.6%. When you look at this efficacy in different patients, somebody starting with 9%, somebody starting with 10%, you can see the efficacy is going to be higher. So somebody who's starting HbA1c is 9.5% is going to get 1.5, 1.6% decrease in HbA1c with this combination compared to using DPP4 alone. Now, looking at the other side, the combination versus just plain SGLT2 inhibitors, again, I think it is very clear that you get much better glucose control with the combination. This is where the baseline HbA1c is about 8, and when the baseline HbA1c is higher, you get better glucose control. So I think the first two part of the pyramid, that is symptom control and glucose control, I think the choice of SGLT2 DPP4 inhibitor becomes a very potent and effective choice. Now, the slightly on the top part or the icing on the cake was beta metabolic control. I think SGLT2 here is going to provide you some degree of weight loss, may not be the extent that you would get with a GLP-1 analog, but still significant weight loss. We are talking in terms of 3 to 4 kgs weight loss, and these studies where they've compared SGLT2 versus DPP4, you can see there is about a 3.4 kilo weight loss that you see with this combination. In terms of safety, both these drugs potentially do not cause hypoglycemia, so we do not have issues with hypoglycemia. But what is surprising initially when I first saw the data was when we used this combination, some of the side effects of SGLT2 inhibitors also were reduced. And primarily the side effect of SGLT2 which were reduced was the occurrence of genitourinary infections, the candidal genitourinary infections decrease. And this is not just with one combination, almost it has been now seen with all the 3 combinations that are currently available. Now, today my job is to, this is a promotional talk, my job is to introduce this generic combination of dapagliflozin and sitagliptin and tell you that whether this is the answer to this pyramid, rather than take a lot of time in choosing the drug, whether this, even in patients who cannot afford, I think this combination will become very affordable because I'm sure there are many, many companies which are going to bring out this combination of dapagliflozin and sitagliptin as a generic pill. Now, we don't have any data of this pill together, but we do have data where this is a clinical trial which looked at patients who were on placebo versus sitagliptin. So these were patients baseline on sitagliptin who were then added dapagliflozin versus placebo. This was for looking at the efficacy of dapagliflozin. It was not to look at sitagliptin here. But what is clear is the combination at 24 weeks, there was a difference of HbA1c by about 0.5%. And at the end of 48 weeks, 48 weeks, there was a difference of 0.7%. So not just the efficacy that is initially, but there is also an efficacy which is sustained. And in fact, it gets better as time progresses. So that is one good thing with this combination of dapagliflozin and sitagliptin. The other things, the beta metabolic control that we looked at, you can see the body weight reduction is about 2 kilos in this group who are using both sitagliptin and dapagliflozin. The fasting blood sugar control already you can see about 24, and also a slight reduction in systolic blood pressure in patients. Now, I think this is a guideline, not really a guideline. This is an expert opinion published in Diabetes Therapy. A lot of leading endocrinologists and diabetologists were here. So now to make things easier, now this is an expert opinion, not the RSSTI guideline, not the ADA EASD guideline. So their expert opinion was, if you have a new patient with type 2 diabetes, initiate with lifestyle modification, start on metformin, monotherapy, if the HbA1c is less than 8%, but if the HbA1c is more than 8%, you know just metformin monotherapy may not be enough, and there may be a choice of using or a possibility of using this combination along with metformin. Again, if metformin is for some reason not tolerated or contraindicated, again, this could be the first choice, a combination of dapagliflozin or sitagliptin. They didn't use this particular combination. They said any of the SGLT2 DPP4 combination could be used. So this is as an initial management. Similar thing as management as a second line on patients who are already on metformin or those who are already on insulin and other agents. This, if they are still not meeting the glycemic target, this could be a good combination to use in them as well. Now, for promoting weight loss, preventing hypoglycemia, both HbA1c criteria, you could use SGLT2 inhibitors, you could use DPP4, but you could use a combination as well. Based on CV risk, you know that dapagliflozin is going to give you heart failure protection, is going to give you renal protection, to some extent is going to give you atherosclerotic cardiovascular risk reduction also. So I think this combination will work, and we know sitagliptin. With some gliptins, we have some worries about heart failure. With saxagliptin, we have these worries. But with linagliptin, sitagliptin, we do not have that worry. So this combination is extremely well suited in patients with CV risk, especially if they have heart failure. Again, extremely well suited because dapagliflozin is one of the most well-studied drugs in patients with renal failure. So that is the reason why this combination is well suited. And we know from sitagliptin studies, though it may not preserve EGFR, it does have some studies in terms of reduction of albuminuria and preserving EGFR. So I think summarizing, we heard masterful talks on all the various things we need to do. But if you are short of time and if you're following a pyramid and you want to decide things quickly, I think if you look at this pyramid in terms of both metabolic control, in both terms of glucose control that the patient can see in terms of improvements in his values, and the icing of the cake, which is vasculometabolic control, barometabolic control, and now what we talk about is viscerometabolic control, improving liver outcomes, improving gonadal outcomes. I think this combination may be an excellent choice, and I'll stop here, and I'm very happy that I was invited here. Thank you very much.